Good afternoon. Thank you for the invitation to give this talk on challenges in training in renal cancer surgery. I'll start by posing two questions. What's the word training really mean? And do we currently have too narrow a perspective on when this training takes place? Here's when my training is said to have taken place. But I would say I've been training as a renal cancer surgeon over a lot longer period than that. This long, in fact. I wasn't operating as a 14-year-old, but I was training. I was having to prepare for physical and mental challenges, play in a team, stay calm under pressure. I was also learning how to enjoy moments of success, but realizing that the next moment of disappointment was just around the corner. Sound familiar? In short, I was preparing for days to come and learning how to prepare. And I'm still training now, striving to improve, to meet bigger and harder challenges. Some of the operations our team had delivered in 2021, we couldn't have done 15 years ago. We weren't good enough. We've trained and improved and continue to do so. And we've learned from others outside surgery. Many will recognize this man, Mike Atherton, a former England cricket captain and now Sky commentator. What have I learned about renal cancer surgery from him? Well, it was from his answer to a question: how do you concentrate all day when batting, when building a big innings? How do you concentrate all day when batting? And his answer: you can't. The key, he suggested, is to be able to relax at the non-striker's end. That allows the mind to fully focus when you're in the line of fire. In long operations, are we generating moments at the non-striker's end? Moments when we can relax and regroup before refocusing on the next critical step. Back to specifics. Here are 6 questions that are pertinent to renal cancer surgical training, I think, in 2021. Questions you might have expected me to pose and answer. Is open surgery redundant? Will this be the future? Maybe, maybe not. Will laparoscopy be redundant? 10 years ago, robotic partial nephrectomy was the specialist operation, and now it's routine. Robo-partial, the starter op. Do you need a fellowship? Is the UK a good place to train? And crucially, who's going to train those consultants who are trying to improve while they work? They aren't the only questions, of course. These might be 5 more. Some quite controversial. Maybe ones we would talk about afterwards in the bar if we were face to face. Back to open surgery, which is my area of expertise. So we're clear, here's what this open surgeon thinks the future is. The future is clearly robotic. But open surgery does seem alive and well at Guy's Hospital where I work. Here's a montage of some of the cases we've dealt with recently. None easy, all open. So it might be worth training in it. Lots of open surgery still in a unit which isn't short of bold robotic surgeons. In the last 6 months, busier than ever. So I don't think we need to write open surgery as obituary just yet. I think there's still a reason to get good at it, to train in it. Might laparoscopic surgery be redundant? Swamped by the robot on the one hand, and unable to deliver the things robotics cannot on the other? Well, I think not. In most of the world, there is a desperate need for laparoscopic training and provision. Robotics for many is a pipe dream. A cheap, safe method of minimally invasive surgery is still highly relevant in so many countries. Something I'm sure the SIU understands. What in the future will constitute the highly specialized end of the market? The things perhaps only a few should do, the training within the training. Well, here's UK data for renal cell carcinoma with IVC involvement. You can see that most centres are very low volume indeed. Not much training possible there, I would surmise. Only 4 centres doing more than 10 cases a year. Probably those are the places to train. And in the ultra-specialist surgery, renal cell cancer requiring cardiopulmonary bypass, the picture is even more startling. 3 cases over 5 years is the median case volume in British units. Surely this is an area where there is no place for the occasional surgeon. How can one train people if one rarely delivers the techniques oneself? By contrast, here are the 8 intracardiac renal tumours we've managed at Guy's and St Thomas's from December 2020 to March 2021. Astonishingly, as many operations in 14 weeks as most units perform in 14 years. And arguably, I would say a better training environment. What about partial nephrectomy? Is open partial nephrectomy an endangered species? Well, clearly it is. A revolution in surgery has taken place in the last 15 years. An operation, robotic partial nephrectomy, has gone from the experimental to the routine. It's been a breathtaking change. And the crucial thing to training, clearly, is robotics. Robotics can now deliver operations in some of the highest risk areas, such as partial nephrectomy in single kidneys. In 2016, much of the single kidney work was done open across the UK, but now in high volume centres like the Royal Free or Guy's, it's done robotic. Notes 2, there are still too many low volume centres in single kidney partial nephrectomy. Is it worth even training in open partial nephrectomy? Well, probably yes, but for some very rarefied circumstances. For these types of circumstances, endophytic, high complexity tumours in single kidneys, Padua 12 or more, we term these operations extreme partial nephrectomies. I mean, there's extreme and there's really extreme, such as this. A recurrent RCC in a transplant kidney 5 years after previous partial nephrectomy in another centre. And the transplant is in a patient who's the 11 times world transplant cycling champion, who also loves social media. No pressure there then. Open surgery and not an operation for the trainee. What about a fellowship? Are they mandatory these days? Yeah, I would say probably yes, but it does depend on what it means. Personally, I think they have to be single disease area fellowships to be relevant to a UK practice. I think there's very little place for a general oncology fellowship these days. And I think you have to be immersed in one area for a year. Total immersion. And in units which are pressing forward, doing new things, difficult things. And one word of caution here, fellowship doesn't guarantee you forever. The field moves. things happen post-fellowship. Here are the new things in the last 20 years in our unit. Progress isn't going to stop. There will be a different set of new things in the next 20 years. I think the UK is very well placed to deliver these renal cancer fellowships because cancer care has been centralised. There are astonishingly high volume centres all over the nation. Our goal at Paus is to make the UK a preferred destination for fellows both from the UK and all over the world. These sort of numbers are not available everywhere. It's not just the complex things, of course, that a fellow needs to learn. Often it's getting the basics right. The right instruments, the right incisions, the right retractors, the right first steps. Dissect the aorta and ligate the artery as the first step in a complex renal cancer operation, and it saves a lot of blood. Can you mobilize the liver to expose the IVC? Can you graft the IVC? Actually, have you even got something as basic as the setup right? This was an extraordinary moment for me. I went to Dusseldorf as a visiting professor in 2018, and I saw something I'd not seen before. Get the scrub nurse in a position where they can see what's going on. It's a much higher platform than I'd ever seen used in the UK, but the scrub nurse can see into the field. And not only that, but the Mayo trays were big enough for everything. There was no need at any moment for the scrub nurse to look away. Proper German setup. Vorsprung der Technik. And finally, who's training the consultants? It's crucial to improve their performance too. It might be the most crucial element to training of all. I mean, one could argue that this best reflects the learning cascade for renal cancer surgery in 2021. A huge element of my learning, training if you like, has been from the other consultants, both in urology and in other disciplines. They've been so important, it's worth name checking them. Two brilliant HPB surgeons, Mohammed Reela and Parthis Srinivasan. The cardiac surgeons we've done all 88 cardiac cases with, Connell Austin. Mark George, my go-to colorectal surgeon. And the two urologists I operate with every week, Archie Fernando and Raj Nair. We train each other. I think Raj and Archie have had a very modern training, and they've been very well trained. Here's a sketch of their training. They're both exceptionally high performing and continue to get better as consultants. I won't address the other 5 questions about training this afternoon. Maybe those things are something for another day. But I will leave you with what I think is a true timeline of training to be a renal cancer surgeon. Thank you very much.